Hello, everyone. Welcome to the first affiliate hospital of Harbin Medical University in Heilongjiang Province, China. And today we are going to work on a very complex CTO case with the LED totally occluded. This is a 41 years old male and suffer from chest pain for 5 months. Risk factor are hypertension and diabetes for two years. Injection fraction is 70%. Laboratory data almost normal. This is electrocardiogram. From this picture, you can see a Q wave in the V1 to V4 and elevated ST segment in these 3 and AVF. Depressed ST segment in these 1 and AVL. This is angiography on February 4th. From this picture, from this meeting, you can see there's a stemless CTO lesion attracts small LED, and you can see there's then in circumflex. And this patient did the circumflex standing operation about 3 years ago. About 50% stenosis at the distal circumflex. Let me introduce the right coronary artery angiography. This is a right coronary artery angiography, and it's very long, diffuse, mild stenosis, right coronary artery. And you can see there's some contralateral to support the LAD, PL, maybe, and there is set branch from the proximal right coronary artery to support the left anterior descending.
The reconstruction showed its patency, but really it is, in fact, it is occluded. But we can see severe calcified lesion in the proximal LAD,
Yes.
and only a little bit soft plaque. Most are calcified lesion. This is why the first time a very well experienced operator, CTO operator, couldn't successfully recanalize the CTO lesion. Okay. Let's see today's angiogram, please. Okay. This is the first angiogram. We can see this is really anomalous ostium RCA, and we use one femoral and one radio approach. This is really a very big guy, very young but a very big guy, patient with OSAS. And the RCA angiogram, we can see some collateral channel to the distal RCA, and with diffuse lesion, especially in the should be in the third portion segment. There should be some maybe a relative unstable plaque there. We can see clearly. So if we use retrograde approach, we may firstly use imaging to check the place and maybe implant a stent there, and to make the retrograde approach is safety.
So this is a manual pullback from the diagonal, and we can see it's a relatively very big side branch, which means that we need to keep this very important side branch patency to ensure the prognosis of the patient. And as the IVUS caster is pulling back, we can see that from the 4 o'clock to 6 o'clock, there is a main LED vessel joining into the side branch. And from this one, we can see it's the LED occluded segment. And also here is some hint for our next procedure. First, it's a very big LED vessel. It's joining into the side branch. And also at the opening of the side branch from the CTO segment, it's very clear. There is almost no plaque. Second thing is that there is some mild calcification on the side of the occluded LED. So which may cause some problem to the antegrade puncture during the next antegrade procedure. And here we can see that this is the occluded LED. Here, this is might be the entry point of the CTO segment. This is what we can see from the IVUS. We can see that Professor Li is performing the knuckle technique using a hydrophilic coated wire. And actually, I think that this is a very dramatic CTO case with a blunt tip of the proximal and occluded LED. There are several things that I think that we need to discuss in full details. First thing is that I think this one is a JCTO score 3 case. There are several things. First, it's occluded segment is over 20 millimeter from the CTO reconstruction and also from the
So at that time,
bilateral angiography.
I think we already did knuckle.
Yes.
So the anti-grid contrast injection should be avoided.
Yes. Yes.
Yeah. So we should use a contralateral
Yes.
angio. Okay.
To avoid the potential anti-grid dissection and
Okay.
hematoma, which means that from now on, the angiography from the anti-grid should be avoided.
Okay.
Yes, I think the knuckle wire has been very near to the distal. And also, like Professor Lee just did, we used a dual lumen macrocatheter to try to help us to perform the anti-grid wire escalation approach. However, we may notice that this dual lumen macrocatheter failed to guide the anti-grid wire into the true lumen because we found from the CTO reconstruction information and also from the bilateral angiography that there is a very big size of the proximal entry point, and also there is some calcification, which all raised the difficulty of the anti-grid wire escalation. And since that, we noticed that there are several questions involved from the anti-grid approach. One question is that what is purpose, how to the strategy of the anti-grid wire escalation? First, we noticed that Professor Lee used an Gaia third wire and switched to a Conquest Pro, and later it's a Conquest Pro 12. And eventually we used the Conquest Pro 12 to engage to the proximal cap of the CTO segment. And then later we are switched to this kind of ADR techniques because due to the relatively not so long occluded segment. And another very important information is that from the 3D reconstruction and also the bilateral angiography, we found there is no important set branch within this CTO occluded segment. When we are mentioning the so-called important set branch, we usually mean that this set branch is performing over 10% of the left ventricular myocardium, and also we can judge from the length of the set branch and also the diameter of the set branch. Majority of the times when the set branch diameter is less than 2 millimeter and also the length is less than 60 millimeter, I think that is relatively small and doesn't cause very severe damage during the crossover and loss of the set branch. So you may notice that we are using an Gazilla as well as an wire in the arterial branch to increase support and also to keep and maintain the coaxial position of the RCA guiding catheter to make sure that the flow is enough for the bilateral angiography as well as to increase support to make the whole system stable. And now we opened this stingray balloon to relatively low pressure. It's a full atmosphere, I think.
So the balloon must be well prepared. Sometimes if the balloon was not very well prepared, we couldn't see the balloon. And the optimal view, the stingray balloon should be one line. Let's choose okay. Choose a view to make sure where is the direction of the true lumen. Not very clear. Okay.
Yes, because we know that this case doesn't, gives a very, good collateral flow from the RCA, vessel to the RAD. There are several collateral flows from the RCA to RAD. One is from distal RCA, and one is from the proximal arterial branch. However, we may notice that either of these collateral flows doesn't offer, big enough and also good enough collateral flows to the RAD. So which, is another, thing that where we perform the anti-grid ADR techniques, not the retrograde approach, because the distal RCA situation is poor. There is long diffused plaque, and also the collateral flow to the RAD it's not so clear. The collision flow is not, well enough to support the retrograde approach. So, Professor Lee, do you think the calcification within the CTO segment is an issue of this, puncture difficulty?
Okay. Okay. Okay.
Okay.
So where is the true man?
I think that from the collateral angiography, I think it's, for me, maybe it's from the upper side. Okay.
Okay, enter again. Okay. Okay. Stop. Not very clear.
Yes, because there is some, mild diffuse calcification, which, influence the identification of the distal entry point. So maybe I
Do you
think that.
think straw may help?
Mm-hmm.
Okay, let's withdraw with the pump for relatively long time.
So like Professor Lee introduced, that we are, switching to the retrograde approach, since the antegrade, stingray balloon-based ADR techniques, they doesn't have a clear view of the distal reentry site due to the maybe potential antegrade hematoma, and also that we can see antegrade parallel techniques doesn't make very good progress. And also, if we perform these ADR techniques in the relatively mid or distal part of our AD, we are taking the risk of losing relatively two or even more relatively big side branches, which is
Andrew,
not
please.
good promise for the good prognosis of the patient. So now we are switching to the RCA, and first we can see there is a relatively long diffused plaque distribution along the RCA.
Look better, I think.
Yes.
Okay, Carwell, please. So at first, I already said no very good.
Yes, collateral flow from the distal
Yeah.
RCA. It seems that
By
the
wire surfing.
yes, it seems the contralateral flow from RCA is a combination of several very small collateral chambers that form the angiography from the retrograde. It's not, good enough, which means to reach the CC level 3 or even better collateral flows.
Yeah.
That's why we are trying the anti-grid ADR techniques first, not the retrograde approach on this case. The far ending of the RCA is relatively long, but it doesn't seem to be connected with the septum collateral channel.
Just to try the surfing.
Because from the bilateral angiography, there is no very clear CC level 3 or above level collateral channel.
Okay, do a super selective angio. Contrast, please. More, a little more. Okay, could be more, please. Contrast.
Okay.
Contrast, please. Okay. Sometimes we also could try the postlateral branch and postlateral branch, but for the postlateral branch, okay, how about the proximal one?
That's a choice, but it's not a guarantee.
Yeah, okay, that's fine.
Good channel,
okay,
yes.
give me the CMR, please.
It seems it's connected to some septum, but it's not. It's unknown is whether usable or not.
Please. Okay, should be this one. Should be this one. Okay.
Yes. Yes.
But
it's hard to say where its exit point.
Yeah, maybe in the proximal portion.
Yes.
Yeah, not really. Okay.
Thank you. Copy that.
Okay. Okay.
Yes.
Yeah, stop. So, I think we could advance a little bit the microcatheter and do a super-selective injection because we already could not. Okay, about here. Okay, give me the contrast, please. So why I don't like to use a retrograde approach for this case? Water, please. Benign water. Benign. Okay. Install. Okay. Because really maybe some double channel, but more close to the distal cap or even okay, you can see the blood flow back. Okay. Okay. Okay.
Yes, it's connected. Yes, to the
AP cranial. I think. Yeah. I
Thank you.
think we are already in the right direction. Okay. Okay.